Hello everyone, today's video is about low-dose immunotherapy. As per usual, nothing I'm saying should be construed as medical advice. This is for informational purposes only. If you need medical advice, please talk to your healthcare provider to get that advice. And if at some point you wouldn't mind, please taking a quick moment to like, share, subscribe, and or post a quick comment on the video. I'd really appreciate it. So thanks in advance for taking a second to do that. So I've been preparing a couple of lectures for a couple of courses/conferences that are coming up. I'm speaking at Dr. Ty Vincent's annual LDI training course. He hosts that pretty much every year. I think I've been to all of them, not in person, unfortunately. They're in Hawaii, and as much as I'd like to go every year, it's just not in the cards. I have too many kids, too many patients, can't get away, but always attend it online, and really looking forward to learning from him. And this year I was very honored to be asked to share my experience with LDI I was going to speak for a couple of hours during one of the days, so I'm looking forward to that. When I was preparing my slides, I just looked at when I started using LDI, and it's been 10 years ago. So I've been using that for a very long time, and very excited to share my experience at his course. And then in early May, I'm speaking at another conference in Ontario, and just talking about using low-dose immunotherapy, more of like an introductory course. So my lecture at Dr. Vincent's course is going to be more like all of the sort of different ways that I use LDI in my practice, kind of more of like a little bit more of an advanced LDI lecture, if you will, whereas the one in May is going to be more of a basic lecture. So anyways, I've had LDI on the brain, and so I thought I would just post a quick video about low-dose immunotherapy. I've posted many of them before, but in case this is a new concept to you or just kind of hearing about it again for the second or third or fourth time, figured I'd post a quick video about it. So low-dose immunotherapy was developed, I believe, about 20 years ago by Dr. Vincent. It's an offshoot of another treatment called low-dose allergen therapy, or LDA therapy. And that's an offshoot of another treatment called EPD, or enzyme potentiated desensitization, which was developed back in the 1960s in the UK by a doctor named Leonard McEwen. And so LDI, the way that I describe it to patients is it's kind of like allergy shots, but different in a couple of big ways. One big way is that there's no shots involved, which is nice. A lot easier, easier for kids, not painful for, well, kids of all ages. Nobody likes getting needles as a rule. And then also we're using very different substances than what a typical allergist or other clinician would use for allergy desensitization. But I'll talk about how it's similar to allergy shots, then we'll kind of go from there. So if a person was allergic to dust, for example, they go to see the allergist says, hey, I've got just a thing for you. We're going to do something called subcutaneous immunotherapy, aka allergy shots. I'm going to inject you with this stuff to help try to get rid of your downgrade or get rid of your dust allergy. Say, great doc, what are you going to inject me with? I'm going to inject you with dust. And then crickets, like, really? Like, you're going to inject me with the stuff that I'm allergic to? It's like, yeah, that's what we do. So as crazy as it sounds at first blush, that is what is done with allergy shots. You're injected with a very dilute preparation of the stuff you're allergic to. And the reason behind that is that we have these special cells in our skin. They're called dendritic cells. It's a type of antigen-presenting cell. And basically those cells in the skin, they identify, or they recognize, I should say, what's been injected, and then they there's this downstream cascade of these different immunomodulating cytokines, and they basically down-regulate the levels of antibodies that are just basically like allergy antibodies that are just waiting to pounce on the allergen. So by doing that, then the next time, after enough treatment anyways, when that individual is then exposed to dust, they don't have as many of those antibodies waiting to react to the dust and causing the typical allergic response. There should be a lessened or maybe nil response. So the patient goes in, week after week, gets these allergy shots of diluted dust, usually with an escalating potency. And then they build up this immune system tolerance, hopefully, if the therapy works. There's an offshoot of subcutaneous immunotherapy, aka allergy shots, called sublingual immunotherapy, also known as slit therapy. And it's the exact same premise, but instead of injecting dust, they use sublingual administrations of this, so either drops or tablets or whatnot of diluted dust. It's like, well, that seems also kind of weird and crazy, but it's not, because we have those dendritic cells under our tongues as well. So you can inject it, you can put it under the tongue. They're both acceptable routes of action, and there's quite a lot of research literature looking at this, kind of outlining this mechanism of action. So Low-dose immunotherapy is actually very similar to sublingual immunotherapy in that it is also under the tongue. Back in the old days, 10 years ago, we were injecting LDIs. Then it became quite apparent that the sublingual version worked just as well, so we started using that. And I don't know if anybody does LDA shots anymore because the sublingual version seems to work just as well. But the big difference though between say sublingual immunotherapy and LDI, low-dose immunotherapy, is the types of formulas that we use. So with sublingual immunotherapy, it might be to animal dander and dust and pollen and maybe peanuts and different things like that. There's select therapies or antigens, allergens that are available. With low-dose immunotherapy though, we're using things like yeast, we're using Lyme bacteria, Bartonella bacteria, Babesia parasite, Mycoplasma bacteria, might be estrogen, progesterone, parasites. There's like a wide range of different formulas. So we use this, and then there are more traditional allergen formulas as well, the things like grasses and molds and different foods and things like that as well. But generally with low-dose immunotherapy, we're using formulas to address a presumed microbial hypersensitivity or maybe a hormone hypersensitivity. So basically folks reacting to, we'll say, like less standard, less common allergens, quote unquote. There's hypersensitivity responses, one type of which is a traditional allergy response, but anyways, for the sake of semantics, we'll just say an allergic response, but it's really technically more of a hypersensitivity response to the allergen or a microbe, I should say, in question. So if a patient, for example, let's say they have digestive issues, they are breaking out in rashes on their skin, they're getting sinus irritation, and they go find naturopathic doctor, functional medicine doctor, and they go on say a low sugar diet, low gluten diet, maybe a lower grains diet. They're put on antimicrobial herbs or fluconazole is some type of a pharmaceutical, anti-yeast, antifungal agent, and they feel a lot better. It's like, great, I had a yeast overgrowth, I'm feeling better, that's great. But then they try to come off the medication and all their symptoms come back. Or they try to come off the diet and all their symptoms come back. So then they go on the diet for longer, they go on the medication for longer, they're doing great, and then they try to come off those things and the symptoms come back. Then it's like, what's going on here? Like, is it biofilms? Is there SIBO? Is there some other thing going on too? Maybe that can be the case, but in some of those cases, it appears to be that they're actually having a yeast hypersensitivity reaction. They're actually reacting to the little bit of yeast that is naturally growing back, because we all have yeast in our guts, in our sinuses, on our skin. So they're actually presumably reacting to that little bit of yeast that's growing back as soon as they stop taking the anti-yeast herbs or medication, or they start eating foods that are going to facilitate a bit more yeast growth. So in those cases, we think you might be having a yeast hypersensitivity reaction, so we would give the patient low-dose immunotherapy for yeast and see if that makes things better. And in many of those types of cases, it makes things improve or sometimes totally resolves the case. So I've had many patients over the years where they were just like, seemed to be painted into a corner treatment-wise, bring in LDI, and that's what cracked the case. So it's an amazing therapy when it's indicated. If you were to take a room full of 100 patients with yeast overgrowth issues and give them all LDI, there's a good chance that hardly any of them would get better because most of them probably just need a yeast overgrowth. But if you had a room full of 100 patients who fit the description that I just mentioned, where they're better with treatment but regress when they're off the treatment, or maybe they only partially improved, there's going to be a significant number of those patients that are likely to improve or get all the way better. So it's a wonderful therapy when it's indicated, and it's been a huge asset to my tool chest in my practice, and I just love it. So anyways, wanted to share my enthusiasm about LDI, and I'll leave it there for now. Any questions or comments on LDI or any other topics, just post in the comment section below, and I'll do my best to answer as soon as I can.